Hello. Today I'll be discussing methods to treat portal hypertension, especially the TIPS strategy, which is a transjugular intrahepatic portosystemic shunt. And it's a surgical procedure typically done by an interventional radiologist to alleviate pressure in the portal vein. Just some background on portal hypertension. The hepatic portal vein bifurcates into the left and right hepatic portal vein and supplies nutrient-rich blood to be filtered through the liver, and then re that blood is returned to the heart via the inferior vena cava, which is not pictured in this diagram, but would run alongside the esophagus to the right of it. However, in cases of liver cirrhosis or liver disease where you get extensive scarring of the liver, you may reduce the ability for the liver to provide a low resistance vessel or provide a low resistance profile to the blood that is flowing through it. And as a result, you can get decreased compliancy and blood accumulating in the vessels before the portal vein. So a great example of this is the right and left gastric vein, where blood can accumulate, as well as the vessel supplying the esophagus. And these are locations where varices can form as a result. It's important to provide some background on how portal hypertension can manifest and what liver disease really is. So before we get into any causes, this is the healthy liver of an individual. It's comprised of your right lobe, the left lobe, and other lobes in the back. And the liver is a very complex organ in that it conducts a variety of metabolic functions. It converts glucose to glycogen as a storage form and breaks down glycogen into glucose. It performs various metabolic pathways involving ketones, the urea cycle, and conversion of non-glucose metabolites into glucose via gluconeogenesis, as just some examples. It produces bile to break down fat globules in the duodenum, as well as creates a variety of important proteins such as lipoproteins, albumin, and coagulation factors, which serve canonical roles throughout the body. However, in cases of steatosis, over time, fat can accumulate in the liver, and the liver, and especially the hepatocytes, the functional cells of the liver, are not well equipped to deal with the accumulation of lipid droplets. In cases of steatosis, the liver, though it may not be symptomatic in a benign condition, is slowly accruing some damage, which really manifests itself in cases of steatohepatitis, where the lipid stores have built up so much in hepatocytes that they are now undergoing lipotoxic damage, which I will discuss shortly in the next segment. Now, over time, what can happen is as the lipid droplets accumulate in these hepatocytes and inflammation ensues due to lipotoxicity and the subsequent production of reactive oxygen species, you begin seeing scarring develop, likely due to an activation of fibroblast-like cells in the liver called hepatic stellate cells. And a major consequence of increased protein production in the parenchyma is portal hypertension, where there's decreased compliancy and overall increase in the tone of the portal venous system. And this prevents the ability for blood to freely flow through the liver and return to the inferior vena cava. Major complication of portal hypertension is varices, which can form, which are essentially, if when you think of varicose veins, areas where your vasculature swells up a bit as it has to hold more blood, as well as ascites. And remember, loss of albumin. Albumin is a major component of your oncotic blood pressure, and it helps hold on to fluid in your vessels. But losing that albumin, as well as increased pressure from portal hypertension, can lead to the secretion of fluid from blood vessels into the peritoneum. You also see in cases of cirrhosis or fibrosis, you see jaundice as a result of the ability to metabolize bilirubin and secrete it in bile. hypoalbuminemia, hypoalbuminemia as a result of not being able to produce sufficient albumin in hepatocytes, which, like I said, could further drive ascites, as well as hepatic encephalopathy. Now, ammonia is converted to urea mainly in the liver, so liver failure can lead to excessive stores of ammonia, which is very toxic to astrocytes, especially in the cerebrum. And this results in astrocyte hypertrophy and cognitive damage over time. And this can be shown as inability to speak effectively and conduct normal cognitive functions. Now, a major cause for this progression from a healthy liver to an ultimately a cirrhotic liver comes from a number of different causes. The most famous one is alcohol, which can lead to alcoholic fatty liver disease. But also viral hepatitis is a major cause, as all those hepatitis viruses, hepatitis A, B, C, D, and even E, all preferentially target the liver as a site of inflammation, driving the production of reactive oxygen species and fibrosis as a result. Now, the one which is most interesting, at least in my opinion, is metabolic syndrome induced fatty liver disease, which was previously called non-alcoholic fatty liver disease, or NAFLD. Now, this condition, which is what these two causes really help target, is mostly driven by insulin resistance. And a huge reason why insulin resistance is such an issue is because of insulin's function on adipocytes. Insulin normally drives the production of triglycerides and adipogenesis as a way to store excess glucose and reduce hypoglycemia. But being resistant to insulin signaling causes the adipocytes to continue breaking down triglycerides into fatty acids, despite insulin consistently signaling to reverse this process. So this failure to respond causes fatty acids to continue accumulating in circulation and ultimately deposits in the liver as a major site due to spillover into portal circulation. And why insulin resistance often comes during obesity is due to aberrant signaling as adipocytes hypertrophy, especially visceral adipocytes, which is why obesity becomes such a major issue in not only metabolic syndrome but also NAFLD. Also, high fructose diets play a major role, as fructose leads to a perceived starvation state due to the way it's metabolized much more quickly than glucose, and as a result, it tends to drive adipogenic pathways in the liver and inhibit beta oxidation or metabolic pathways to break down those fatty acids that accumulate. So fructose and insulin resistance are two of the major drivers of metabolic syndrome in the context of NAFLD, which drives this progression from a healthy liver to a cirrhotic liver. Now, other reasons why cirrhosis is so dangerous are also outlined here. Mainly, it comes down to driving inflammation and fibrosis. But more specifically, we can look at increased permeability of the gut and the small intestine to microbes such as bacteria and their toxins, such as lipopolysaccharide and other endotoxins, which can drive inflammation via activation of toll-like receptors. These are canonical receptors which respond to these uniform pathogen-associated patterns. Also, we see activation of hepatic stellate cells, these fibroblast-like cells in the liver, which can secrete extracellular matrix proteins and lead to overall scarring of the liver. And lastly, lipids themselves are toxic to hepatocytes, which drives the majority of this inflammatory signaling. And this is due to all steps in beta oxidation requiring the production of oxygen reactive oxygen species, as well as production of triglycerides in the endoplasmic reticulum, also producing reactive oxygen species, especially when overloaded in the term we call ER stress or endoplasmic reticulum stress. Now, to return to tips and how we can alleviate portal hypertension, it's important to look for two major indications, which are also two of the major concerns in portal hypertension, which we initially touched on. The first one is ascites. Now, this is an interesting diagram because we also see caput medusae, or the accumulation of blood from portal hypertension in these extrahepatic superficial vessels. But ascites is essentially additional fluid accumulation, especially in the peritoneum, due to not only increased pressure in these vessels that lead up to the portal vein, but also due to a slight loss in albumin and the ability to retain fluid in vessels. As you can see, the patient also did have some edema in the lower extremities as a result of this. So ascites requires almost weekly paracentesis procedures, essentially suctioning the fluid in the peritoneal cavity where it accumulates, which is an essential procedure as it can compress other organs in the area, especially the lungs. But refractory ascites is an indicator that a more permanent solution needs to be put in place, which in our case is a stent between the hepatic vein and portal vein to almost bypass the portal venous system. But also the second and likely more dangerous risk and indicator for the TIPS procedure is varices in the gastrointestinal system. So both these diagrams show great representation. This one shows how all these vessels lead up to the portal vein. We often see splenomegaly in portal hypertension. As you can see, a lot of blood ends up accumulating in the splenic vasculature. Also, esophageal varices are especially dangerous, and many people end up vomiting blood or having bloody stools because of varices that accumulate in the GI system. So here, I believe this is the right gastric vein going up to the esophagus has been showing blood pooling. These oftentimes end up leading to internal bleeding in the GI system. Now, the solution for both of those conditions, at least a more permanent solution than continuous paracentesis or colon or endoscopies to treat those varices, would be the TIPS procedure, where essentially a stent is introduced between the portal vein, most often the right portal vein, and the right hepatic vein for the most part, though other veins can be used. In this vein, in this stent essentially helps pass or bypass the small circulation of the liver that ends up accumulating a really high resistance in cases of portal hypertension. Now here I wrote that it's somewhat permanent because for the most part, TIPS is still a transient procedure in place of a patient waiting for a liver transplant. As they're on the wait list, as they have a very late stage cirrhotic liver, they need a transplant. But this helps alleviate some of those conditions which we see as a result of portal hypertension. However, there are some contraindications which would lead us to avoid the TIPS procedure, at least until we stabilize these concerns. The major one, which is unlikely to be stabilized, is unfortunately cancer of the liver, which is more and more common as you get later on into liver disease. So metastasis of the hepatocellular carcinoma or a rupture of extrahepatic cysts, which are cancerous, can lead to spread of the cancer in various regions. Now, bypassing, or if there's a tumor along the way of the stent is also another indicator. Now, these will either indicate that any care for the patient is palliative in nature, or that increasing the shunt can further increase the risk of metastasis of that cancer. Also, existing encephalopathy, as TIPS is one of the major concerns with TIPS is that it worsens hepatic encephalopathy, as bypassing the liver means that more of that ammonia would essentially not be converted to urea, and it would reach the brain circulate the brain the brain blood supply. So if there is existing encephalopathy, that would first need to be addressed either by pharmaceutical interventions to alleviate that ammonia buildup, or by ensuring that a small stent's at first placed, and then an appropriate size of lumen is found that allows for alleviation of some of the portal hypertension, but doesn't exacerbate existing encephalopathy. Also, due to an increased blood volume and pressure buildup in the inferior vena cava due to the shunt, patients with right-sided heart issues should be wary, and consultation with a cardiologist may be suitable to ensure that they get the best care based on their complex needs and needs from their liver as well as from their heart. So the TIPS procedure has a number of different steps. As you may recall, it is an interventional radiology technique, meaning that it mainly involves continuous imaging throughout the procedure and is minimally invasive, which is surprising considering how intricate the procedure is within the intrahepatic parenchyma. It begins with entry via an angled catheter in the right internal jugular vein, which is right here. Usually it could even be conducted with the external jugular or the left jugular vein as well. The catheter is inserted down the inferior vena cava to the hepatic vasculature, and CO2 is oftentimes injected to visualize that system. And I will show you a great diagram on the next page. A needle is then inserted via the catheter to the area of the hepatic vein. It's used to puncture the parenchyma and ultimately enter the portal system, where a stent is then inserted to maintain a patent passageway for blood to flow. As you see here, the first step is the insertion of this catheter through the superior vena cava. This procedure shows that the catheter has many parts, including a long flexible tube, which is made of a certain material so that it does not damage the endothelium, but that it flows smoothly to the site where we need it. It's almost seen as a guide. While ultrasound and CT can also be used to assess the location of the catheter and the patency of the portal vein and hepatic vein system, the method of choice in most recent studies now is using a procedure called a wedged hepatic venography, or portography in this case, using carbon dioxide. So when the catheter has been inserted to the point of the hepatic vein junction, carbon dioxide is often injected and picked up by a scope to assess the location of the catheter and needle, as well as what the venous architecture looks like. Primarily ensuring that the catheter is in the right place and in the right orientation. As you can see here, this large vessel here is the main trunk of the portal vein, and this is something similar to what you would see in this case. When you ensure that the catheter is in the right orientation, you can insert the needle very thin needle through the catheter to the site that you are looking for, and you want to get it right in the beginning of oftentimes the right hepatic vein, though the center and left hepatic vein can be used. You want to pull it up slightly so that it aligns with the orientation of the inferior vena cava, and then you quickly push the needle through at the insertion site of the superior vena cava at the internal jugular, and you puncture through this really thick fibrotic parenchyma so that you can enter the right hepatic portal vein. And once you do that, you repeat the same procedure with CO2 to ensure that you've entered the correct site. As a reminder, this is pictures similar to what you might see on live imaging when you have entered the correct venous system. And once you've ensured that your needle and guide has entered the portal vein, what you can do is insert a balloon catheter into that site, into the parenchyma, and you inflate the balloon catheter so that you can ensure you maintain a patent airway in the stiff liver parenchyma. Now you want to ensure that you have not ruptured any major vessels along the way, as this can lead to internal bleeding and complication in a rare complication of the procedure. The next step in this procedure is inserting a stent through the catheter to the site where the balloon catheter was originally inserted. In that site, this stent has two parts. One part that is covered by special material, another part which is not covered. Now, the concern with covering of the stent is that it can impede the ability for that blood to flow through the liver. And of course, this can exacerbate conditions like hepatic encephalopathy, where toxic metabolites are essentially damaging the brain and central nervous system. However, ensuring the patency of this shunt is extremely difficult, which is why the covering was vouched for in the first place. So this will come at a patient-to-patient variability, and it may need to be constricted, the shunt itself, should the patient eventually develop symptoms mirroring that of hepatic encephalopathy. Otherwise, the covered portion of the stent falls in the parenchyma of the liver in that duct that was created by a needle, whereas the uncovered part fits into the hepatic portal vein, likely right around that bifurcation we talked about. This allows some blood to escape and flow through the liver as well to get filtered. And a pigtail catheter might also be inserted at some point once the stent is in place and inflated to assess the pressure of the portal vein now in comparison to prior to the procedure, as a way to see whether the stent has effectively reduced portal pressure, and it gives a good indication of how the patient might progress as they continue alleviating some of this pressure. All in all, the patient is then stabilized following their bout with general anesthesia, and the catheter is removed, and a small bandage is placed on the site of insertion. However, the two most important notes to remember following this procedure is to ensure that the patient and the care team remain vigilant for signs of hepatic encephalopathy. And should it occur, they can prescribe something such as lactulose, which is a drug which helps keep ammonia in the colon. In this case, it helps convert ammonia to ammonium and keeps it in the colon and prevents it from entering circulation and traveling to the brain, damaging those astrocytes. Another method is by adjusting the shunt size, likely by decreasing the size of it so that more blood can get filtered by your liver and the ammonia can be converted into a safer metabolite like urea. It's also important to ensure that the shunt remains patent, as oftentimes the parenchyma tends to constrict the, the shunt and it will lose its efficacy, leading to the return of portal hypertension and further refractory varices and ascites. So ultrasounds at 1 month, 6 months, 12 months are protocol for ensuring that the shunt remains patent. But all in all, the TIPS remains a very important procedure to ensure that patients with portal hypertension can alleviate some of their symptoms prior to a transplant and to prevent significant bleeding over time from the varices that accumulate from portal hypertension. I hope you enjoyed, and thank you to the 3FO3 teaching team for facilitating this opportunity to delve deeper into a topic of interest for me.